Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and great day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
A quick reminder before we get started, you can always send us your questions on LinkedIn or YouTube, or send them directly to us in an email at hello@minglehealth.com. In our last episode, Dr. Mingle, you provided some great explanations and context about the data required for quality reporting and where we get that data. We're going to continue that conversation in this episode. And so my first question for you today is, what is it about practice management system data that makes it so great for denominators?
There are a number of reasons that practice management system data, specifically claims data, is great for denominators. Those reasons include it's available, it's highly standardized, and it's got a good perspective, a useful perspective. Practice management systems were the first health information systems to go electronic. They've had a lot of time to mature and to standardize. Medicare long ago drove standardization of the healthcare claims system around the HCFA, that's Healthcare Finance Administration, the HCFA 1500 claim form. It's a reliable and pervasive standard. Nearly all insurance companies use that standard to accept their claims. And that perspective is nearly ideal. There can be a little more to it than this, but the best documentation that a patient-doctor relationship exists is its tracks through the billing system and a record of the encounters in the practice. There's no more reliable record of that patient-doctor relationship. Included with each claim is the foundational data for all denominators. It identifies the practice and the provider. It identifies the patient, including gender, date of birth, and address. It identifies the insurer. It identifies the diagnoses addressed during that visit, identifies the services provided in that visit. It defines or it describes the location and the date and time of that visit, and sometimes even the duration. It's a solid foundation. If the insurer, including Medicare, is questioning the accuracy of your analytics, that data is accessible to them to test it. Now, it's less useful these days while Medicare is moving to all patients, all payers, because Medicare doesn't have access to all payer data from other insurers. But again, whatever they do to verify your data is most easily done by them through the claims. It's simply a solid foundation. We often need supplemental clinical data to further refine the denominator, but claims gives us a first pass identity and count of denominator eligible patients or visits. We call these denominator candidates. It sometimes requires additional clinical data to complete that denominator eligibility determination and the final denominator count. For instance, we can know from claims that a patient is hypertensive, but we need clinical data to know that they are on a diuretic and should have a periodic potassium determination. With claims data, we build the foundation of your quality reporting system. We identify your patients, their diagnoses, the services you provide, a preliminary count of your eligible instances. Clinical data can decrease the count of eligible instances for any measure, but your true eligible instances will never be larger than the number we identify from your claim.
Okay, so now that you've told us about claims data and the value of claims in determining quality measured denominators, what about numerators?
Numerator data is typically clinical data. A numerator is typically answering a question about care of those patients or visits we identified from in the denominator from your claims data. It's typically something like, did the provider prescribe an indicated medication? Was an indicated test ordered? Did treatment lead to control of the blood pressure, hemoglobin A1C, depression, or recovery from whatever was being treated, or control of whatever was being treated? Clinical numerator data can come from a variety of sources, and there's a lot more variation in clinical data than in claims data. Variation relates both to the variety of possible sources and to variation in the structure of the documentation within each source. Now, numerators can come from claims data. We need to realize, though, that claims data has two principal sources. It can be practice sourced or it can be insurer sourced, and there are different strengths and weaknesses of each. You can find things like flu shots, pneumonia vaccines, mammography, screening colonoscopy in claims data. This type of clinical data is usually pretty reliable. It's rare that these kinds of interventions are provided but not billed, or billed but not provided. An insurer can have a pretty complete record from claims for shots in its population of beneficiaries or other procedures such as mammograms or colonoscopies. But a practice will only have claims evidence for the flu shots or other procedures provided in the practice. Most of these procedures are available from a wide variety of locations, and wherever it's performed and billed for, it's just as pertinent to the quality score of the provider. Now, mammography is more extreme and colonoscopy yet more extreme. The provider ordering the mammogram or the colonoscopy is rarely the source of that procedure and its billing. So it's not typically available from provider-sourced claims. And for interventions with a longer appropriate interval, claims becomes less and less helpful. Mammograms needed once every 2 years for the eligible population. Colonoscopy required once every 10 years for the eligible population. Changes in providers and changes of insurers during those time frames make that data less accessible and less reliable. If I'm trying to measure something that happened in your practice, it's relatively easy to get all of your claims. It's also relatively easy to get insurer source claims from one insurer to learn what happened outside the practice. But if I'm trying to measure a specific thing that happened to any of your patients through any insurer, it's extraordinarily difficult to get timely and reliable claims data from all of the 900 health insurers doing business in the United States. And most of those insurers have multiple insurance products and stratify their operations regionally. So there's multiple sources, far more than 900 sources of insurer sourced data. Most often, we get our numerator data from your clinical data. It can be the legal medical record that can be either a paper chart or an electronic record, or it can be a derivation of the medical record, like a tumor registry, a diabetes registry, or any other list of patients' interventions and or outcomes that you or someone for you manages. We need an understanding of the strengths and weaknesses of each of those sources and its potential errors to know how to treat the data, particularly what we conclude when data is absent. For paper charts, quality measurement usually involves manual chart abstraction. Guided by the electronic assessment of denominators, we can reduce the effort otherwise required for you to abstract the charts. Manual abstraction may also be the best way to get certain data out of electronic charts, particularly when the needed documentation is unstructured, text-based documentation.
So our final question today, Dr. Mingle, is about automating quality measurement. So if our clients want to automate their quality measurement process, do they need to be using the Fast Healthcare Interoperability Resources Standard, also known as FHIR, which we spell FHIR?
I think we should all be advocating for the FHIR standard. but it has less immediate impact on your choices and your function than you might think. FHIR, that is the Fast Healthcare Interoperability Resources Standard. FHIR is a means to an end. You should invest most of your time, money, and energy in getting to that end. That end is high value, highly reliable, highly effective healthcare. FHIR is just one credible path and one step in that credible path to that universally desirable end. You should advocate for FHIR politically. You should pressure your vendors to provide it by asking them how much they support it. But I don't think you should include it today in your buying decision. You need to measure the quality of your care today. It can make a big difference in your payments from insurers, particularly for Medicare. Your quality scores are increasingly visible to your patients and affecting their provider choices. And you need ultimately to grow your measurement system into a scalable and sustainable measurement system to help carry you into our high value healthcare future. Buying FHIR today is a bit like being the first in your community to own a fax machine. Who can fax to you? Who can you send faxes to? There's no problem really with the FHIR standard. It's a good standard. It's usable. It's better than most, maybe all, alternatives. More vendors are capable of it than actually use it. As it gets into broader use, we'll find holes and weaknesses in it. And once found, we'll fix those problems and eventually evolve the standard into something better, and perhaps even with a new name. It will not be FHIR as we know it today that you will integrate into your future systems. It may not be called the Fast Healthcare Interoperability Resources Standard. It will evolve just as the HL7 clinical data architecture was the basis of and evolved into FHIR. Now, we at Mingle Health can read and incorporate your FHIR source data into your quality assessments. The three big problems we face today with the FHIR standard: one, it's not in universal use. We can't get it from everyone. Two, when used, the data is not universally populated with accurate, usable data. The biggest problem is that documentation still relies far too heavily on free text without enough structured documentation in your medical record to populate a FHIR message. Until all of your healthcare data is machine usable, FHIR really can't take hold. If your data is structured, our job becomes easier and we can provide more and better data for you to improve and prosper. And it makes a bigger difference to us and then ultimately to you to migrate off text towards structured data than it does to migrate to any specific standard, be it HL7 CDA or FHIR, QRDA, RX norm, SNOMED, LOINC, CBT, ICD. We can really move data around between those standards fairly easily compared to our ability to read your intent from a unstructured textual entry. There is a bigger difference in function and utility moving from that unstructured textual entry to any structure than it is migrating between structures. The biggest barrier between the current state and adoption of the FHIR standard is the lack of structured data documenting the patient's typical annual healthcare experience. Let me go a step further. FHIR is an intermediate outcome. You're becoming more familiar with the term intermediate outcome as we talk about quality measurement. But in that measurement system, I think it's just as valid a concept. FHIR is intermediate. It's not the desirable end in itself. It is one of many potential intermediate goals to get to a fully digital system. And even a fully digital system is intermediate. It's not what we want. What we want is the end result of that fully digital system, that overarching goal of high value, highly reliable, highly effective healthcare.
Absolutely. And that was a really great explanation about FHIR. I found it really helpful, and I hope our listeners do as well. So thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you out there for listening in and sending me your great questions. As always, we can be smarter together.